Now I will introduce our speaker. Christy Knickerbocker, MSCCC SLP, is a speech-language pathologist and singing voice specialist in Fort Worth, Texas. She rehabilitates voice and swallowing at her private practice, ATEMPO Voice Center, lectures on voice science nationally, and has been published in peer-reviewed voice journals. Knickerbocker continues to develop a line of instantly downloadable voice assessment and voice therapy materials on TPT or her website. Christy is a co-founder of the Confident Clinician Cooperative, providing education and mentorship in voice and private practice. Please welcome Ms. Knickerbocker.
Hi, everyone. Good morning. Happy Thursday. I wish I could see you all, but Danny promised she'd send a picture, so I'm sure you look great and you have your coffees, maybe some tea, and you're ready to dive right into this. So I need to tell you my disclosures before we begin. I am owner and operator of ATEMPO Voice Center, LLC, and I'm a founding partner of the Confident Clinician Cooperative. I draw salary from both of those companies. These opinions are my own. I try and keep things a little spicy because nobody likes boring lectures. So, and from my experience as well as being evidence-based from journals. I'm really excited to speak this morning for you all, and then I get to come back in the afternoon, and I am being compensated to speak for you all today. And then I have some non-financial disclosures. I choose to participate in voluntary research with Texas Christian University. So this is to kind of get the mood going, kind of a fun video about what we do. So that was a TikTok when I was deep into TikTok during the pandemic, just kind of coming together with all the things that we do in the voice realm that might look a little different than articulation or language, or even stuff for TBI or an aphasia. Here's what today is going to look like. I'm coming up on that part of the introduction where we'll finish that up. We're going to do 45 minutes on evaluation, kind of some up-to-date things, what you should know, what you want to make sure you're considering and including when you're initially evaluating a patient with voice complaints. Then we'll go into 40 minutes or so of treatment of voice, and we'll split that into direct and indirect. That'll become more clear as we go on. And then I have some case studies that I've brought with some video, some audio examples, and stuff that you can really kind of sink your teeth into, as far as it's not just the things to do. It's like, here was a person, here's how they presented, and here's what we did, and here was the result. And then here's your learning objectives for the CEU credit for today. All right, so part one, we're going to talk about evaluation of voice, and we have to start with the components. You know, what are some things that you want to consider having or including in an initial evaluation? You definitely need a case history, patient reported outcome measures. We're going to talk about these in depth in a second. Instrumental assessment, if you have it available to you. You don't necessarily have to have that at your location, as long as there has been one completed or to be completed before you make your treatment plan. An acoustic, an aerodynamic, and a perceptual assessment. Stimulability testing, so how do they do with what you give them? That guides your treatment. And goal formation and education. And I know that seems like a lot to include, but I can usually get most of that done within 50 minutes to an hour, as long as the patient isn't talking and sharing a whole lot of the time. So kind of a balance that you learn. But if you don't finish those things in the initial time allotted, that happens to me, and you can just continue that on in the first session. So what do you gather? I start with a pertinent medical history, things like recent intubation. You know, have you been intubated recently? Because I would suspect lesions or paralysis or paresis if the person was coming in with a voice complaint with a recent history of that. Maybe they've had a thyroid surgery recently as well. So I'm going to automatically suspect some sort of nerve damage, especially if they're extra breathy and they sound like that. You'd want to gather these recent changes because there's usually a clue within this information to lead you to a diagnosis, or at the very least, the next step for your evaluation to take. And what are we looking at too for this? We want to notice if there's been a change in patterns for the patient. Like, what was the onset? Has something changed very recently in their life? If it was a sudden change. Sometimes the voice patient complaint is a gradual change. And so they're really not sure. Their spouse may come with them and they don't really know when it started. They just know it's different than it used to be a few years ago. So why do we gather these things? We want to get a better idea of what the patient has gone through to get here. I always want to know, are you here because your doctor wanted you to come? And I'm not shy about asking that. Or did they want to seek treatment on their own? Do they have some sort of plan to check and make sure it's not cancer? That is quite a few people coming in. Or do they want to make a change? And are they motivated to do so? So none of those questions are too awkward to ask a patient. I want to encourage you all to be very brave about what brought you here today whenever you have a patient with voice complaints. And I included this here. This is just a redacted part of my notes for an evaluation for a person who had a gradual voice loss in August of 2020. So in this example, I defined when the voice loss occurred. Was it gradual or sudden? And then what were the circumstances? So this person went back to teaching in person 6th grade, had some voice loss, was given steroids. So how they were treated. How did she respond to that treatment? Improved slightly. And then a month later, she was given a second dose of steroids. And how did she respond to that? The voice actually became worse. Then a few months later, she got COVID, and which likely exacerbated her symptoms. Her voice continued to be poor. And she's got a couple of things defining that. She also received some proton pump inhibitor treatment and recommendations for glufenicin or Mucinex. What's she feeling? I always like to include not only kind of an objective medical history and treatment history, but what are they complaining of? And a lot of times I'll put their thing within that, what they've said in quotations under current level of function. But I want to know how they feel when they talk. I want to know how they feel about the voice problem, and then how do they describe how it's presenting. And then I like to, include a prior level of function. So then we include patient-reported outcome measures. So this list I'm going to give you here today is not an exhaustive list by any means, but they're pretty common. There's cough severity index as well, trans woman voice questionnaire, and more are developing all the time. So these are kind of the main ones that I use. I use the vocal handicap index, which is a 10-question questionnaire that's based off of the original VHI, which I think was 30 questions. It's just a lot quicker. People hate paperwork. I mean, if you ever go to the doctor, you think, wow, that's a lot of paperwork when it's more than 2 or 3 sheets of paper. So the VHI 10 is still really sensitive. If a patient sings in any capacity, church choir, they sing in the shower, they sing in the commute on the way to work every day. If they tour professionally, singing VHI is appropriate for them. They don't have to necessarily be a formally trained singer to benefit from you taking patient-reported outcome measure like that. Reflex symptom index. It's important to note the numbers here on this one, but at the same time, I go back and look at what they're answering. There's lots of different questions on the RSI that could lead you to think, is this really reflux, or could this be something else like allergies? Because a lot of those questions can kind of go both ways. So as far as the numbers, I will also look at how those questions were specifically answered. And then maybe you're seeing somebody for breathing complaints they think is asthma. The pulmonologist or the ENT has maybe said, hey, is this vocal cord dysfunction? And this helps assess that as well. I get a lot of calls, emails, DMs about norms. People are trying to know what the norms are, how they should use them when they have them. Do they matter? How they should interpret them and then apply them to the treatment plan. My easy answer to do they matter is yes, but kind of not. So What I mean by that is they matter to see if your patient is very, very far away from the norm. That's going to signal a really huge deficit. But that doesn't automatically mean they have a problem, is the other half of that. So just because you're seeing a deficit in one area doesn't mean that's enough to support your diagnosis potentially. So it's the ability to look at all of the testing that you're doing and then determining, does that matter? How does that all play out and how does that add up? We do use proms to get a baseline, and you can compare to the norms, but if you didn't, it wouldn't be the end of the world, because you can re-administer these proms if you suspect progress or lack thereof in your patient. And it's a good thing to do if your patient's kind of like, I'm not sure if voice therapy is really working. I'm not sure if I'm a whole lot better or any better at all. Or if they feel they're worse, you can re-administer that. Use these along with the other measures you take to determine sufficient evidence for the diagnosis. Why are we giving these? Well, because the patient's opinions and feelings, which a lot of these questions pertain to on these questionnaires, they matter for understanding their complaint and what they have going on, their diagnosis. And they actually help you as the speech language pathologist form goals that are measurable so that everybody can work towards improvement. Videostroboscopy examinations are the most widely available and beneficial exams at this time. So there are more sensitive exams that they're using in labs. There's less sensitive exams that are being used nationwide. But for the benefit that you get as far as the diagnosis accuracy, if you have the ability to refer your patient for a videostroboscopy, no matter how old they are, I would suggest getting it done. So in this picture, this is my daughter. She was maybe 4 or 5 at the time, but it's a rigid scope, and we used some numbing spray, but we were able to get a view of her vocal cords. So it can be done. They change these exams. The diagnosis is about 48%. So it's roughly 50% of the time after a routine ENT examination. And that routine exam might include a mirror exam where they're just kind of sticking a laryngeal mirror in the back of the throat. And it might also include a flexible laryngoscopy where they're looking with their eye or even with a continuous light source into the nose cavity down to view the laryngeal structures. But my hope is to further your knowledge of how this exam can benefit your practice as an SLP. And if you want to screenshot or to take a picture of this slide where you all are, this article, I think if y'all have this is on the slides too, the handouts, but Ash has got a really great recommendation for how to administer instrumental protocols for voice within this article. I think it's a really, really great resource. This is something that simulates slow motion during sound production. The flicker-free images influence our perception with no real motion. So we're not really seeing the slow motion. I kind of say it's fake almost, but it's definitely more than we're able to see with our naked eye. It does take still shots at different points of the vibratory cycle. We're going to look at some actual stroboscopy exams in the case studies later on in this presentation. And for what it costs, it's pretty effective as far as the ability to acquire this. It's not hundreds of thousands of dollars to get a machine like this. And you have options. You can do rigid through the mouth, you can do flexible through the nose, and these advances with the distal chips, it just makes it so easy and so nice to see. And you have a microphone on the neck. It's called a contact microphone to gather pitch. Here's just a few brands. I have no disclosures here. There's good and bad, I think, with everything. There's price differences in all of these as well. Patcom's newer to the market. Pentax has been around a long time. And these are just kind of what they look like as far as the machines themselves. But you can see that they have the ability to show the patient what's going on better than just looking with your eye, and has the ability to record. So what's the difference in flexible videostroboscopy and rigid? Well, you want to consider what you're assessing when you're choosing or referring out for a particular type of this exam. You might want to use the flexible on this left side. If you're assessing performing voice, they can sing. They can make all kinds of noises, screaming, singing, high notes, low notes, with words. They could potentially even bring their instrument while you scope them, if they can tolerate that, and play and sing. You can assess continuous speech with a flexible scope because it's going through the nose and you're not limiting the tongue, lip, and teeth movements. You can assess, not that you can assess paradoxical vocal fold motion with rigid, but you can assess PVFM as well with the flexible videostroboscopy. And you might switch to this. I start with rigid most of the time, and I will switch to flexible very quickly if there is a hypersensitive gag reflex with the rigid scope, because one try, two try, if they're retching, or even I see a little bit of vomit come up from the upper esophageal sphincter, I quickly retreat and I say, what do you think about me going through your nose? I know you're gonna feel a lot of pressure in the nose, but this gag reflex is pretty strong. Also, if you need to visualize other structures, so ENTs are likely using this view because they're looking at the nasal turbinates. They're assessing belopharyngeal function. They're looking at kind of gross motor movements as well. If you know you're just going to be focusing on the vocal cord tissue, you might choose rigid. So why would you pick rigid? Maybe you want to see sustained phonation. Maybe it's a muscle tension dysphonia patient that came in, but they talk like this. But then if they go it switches to a more functional voice. You can hear it a lot better. So you can provide that to your patient and say, hey, look what you can do. Let's listen to that and let's actually look and see what the vocal folds are doing here. I mentioned this earlier, when you have a need for close-up visualization of the vocal folds, the rigid scope has a set view range. So you're just seeing a certain space. You can get that centered pretty easily, and that's a benefit to the rigid. And again, you can assess PVFM here. You just have them potentially go and do something that might induce an episode, or if it's smell driven, present the smells to them as they're doing that exam. But you want to just make sure you're accounting for, is this a gag reflex? Is this something to do with the scope being in their mouth? Or is this something that they're actually presenting with? If your patient has history of a vasovagal response, which is fainting with doing a nasal endoscopy, or if they just faint very easily, this is a good option to try. Most people really surprise themselves, and they're able to tolerate this pretty well. If you want to see anatomic variation, if there is some sort of anatomic variation obscuring visualization, that means maybe their nasal turbinates are really, really swollen. You can't get the scope through. It's really painful for them. If their epiglottis is omega shaped, or if they have some sort of growth or tumor that's causing an issue up in the velopharyngeal port area, you can bypass that by doing rigid. So what can you expect if you do these yourself? What do you have the patient do if you're wanting to train in this? Or if you have a patient who you need to send out, what can you expect that they're probably going to do so you can counsel them and talk to them? 3 complete breath cycles. Diadochokinetic task for the larynx. So that's going to be he, or e. A sustained E at a typical intensity and pitch. A sustained E at varied pitches. E. Or glides. E. Sustained E at varied loudness levels. So E, having them be really soft. E, having them be quite a bit louder. And then singing or continuous speech if needed. For my singers, if they're having a certain set of notes that they're being challenged by, I will locate those notes prior to the exam. I will have them practice them. I'll have them hold the keyboard in their lap and I'll have them play those notes and then aim for that. Sometimes I can stop what I'm doing a little bit and use my elbow, but it just depends on the patient's toleration. But you want to get as much recorded as possible. And this is just kind of what's normal. And then I have a little atypical abnormality over here on the right. But we're seeing this view of the vocal cord tissue. Your entrance to the esophagus is back here. We call this either the posterior commissure or the interarytenoid area. I've heard it called that by ENTs, just reading their reports as well. And then the trachea, you can see those tracheal rings. That varies patient to patient. Sometimes you'll see this many, like 5 or 6, and sometimes you'll just see that first upper ring. Just depends. You're definitely looking in that area though for any kind of closure in there, any kind of potential abnormality there that limits your view, especially if they're complaining of breathing problems. True vocal folds, false vocal fold is here and here. And then we call this piece right here the anterior commissure. This is where you're looking for stuff like webbing. If they feel like pitch range is restricted, or their voice is higher pitch than it used to be, and that's not normal for them, you'd expect to see some sort of maybe overgrowth here of something that maybe they'd had a lesion burst, and then that kind of joined that tissue together and created a web. And then over here, this is actually my spouse, and he has this part of his hyoid bone sticking out. He feels like he gets food caught on this all the time, and was a really great guinea pig at one time. But I've seen a couple people since then who have had this as well. But there can be a whole lot of normal in these exams that isn't really contributing to the person's symptoms. So we have to keep that in mind. And those studies are really valuable. There's a couple of them that have been completed that talk about what's pretty normal. So behavioral assessment is perceptual. So like, what are you hearing? What are you seeing? I start assessing, which I hope you do too, as soon as you grab that person from the waiting room. You're looking to see how they respond to when you say, hi, how are you doing? You look to see their energy level. How are they breathing? What do they sound like when they're coming back to the room? What do they sound like when they're telling something that's exciting? How do they look when they phonate? So when they create sound to talk, do you see anything extra as far as their muscle use or just something that's off about it? Maybe they talk really fast and then they breathe in and out like that. And then they're talking, and then they breathe. So things aren't coordinated. They're not breathing in and then talking outward on the breath as it leaves their body and then breathing back in to replenish that. So things that you're noticing. Also, perceptual for you is how do they feel? So 2 ways of feeling here. How do they feel when you palpate, when you touch their larynx, when you touch their head and neck areas? You always want to ask permission. You know, are you okay if I touch you in these areas? It's going to be a light touch. I'm not going to do anything without your permission, and make good on that. You know, continue to ask them consent for what you're doing to help assess. But then how do they feel? How do they react when you're palpating? Do they tense up when you touch on their larynx? Do they hold their breath? Do they have eye movements or do they clench their eyes really shut? Indicating to you that either there is some sort of discomfort or maybe even a sharp pain. And so you want to keep that line of communication open with that. Perceptual assessment can be something like the Cape V. You might want to use this. There's other ways to assess this, but this kind of gives a quantifiable measurement of components that we hear in the voice, not just saying, oh, they're hoarse and it's moderate. What makes up that hoarseness? And it allows you to add additional features like, you know, vocal fry. They had vocal fry this % of the time. You know, the C means consistently, I means inconsistent. And you'd add that there. You can also consider, or maybe you grew up in your schooling using the Gerbos, which is a different way to assess a lot of the same terms, except asthenia. The A stands for kind of a weakness. You know, does the voice sound weak? Which you could add to this one, but it's not one of the main components. Quantitative, I said that earlier. It means that you can have objective scores. So something that is not easily changed by just saying it's very bad or it's super rough. What does that mean? It's rougher than it was yesterday. I don't know what that means either. And you can easily measure this repeatedly. So this is a nice thing you want to have. Acoustic assessment is quantitative. It can include a voice range profile. You want to make sure that when you're gathering your acoustic measures, you do this because you want to get a full picture of how the parameters in these parts of the voice actually are represented. So these are things like loudness, pitch, as well as quality. So it's not just what we're listening for, it's like, what is it? How is it in time? Acoustic assessment needs to be sensitive to the severity of the disturbance. So this allows for better specificity than just saying it's a mild voice disorder or it's a severe voice disorder. And it can provide indirect inferences regarding underlying pathophysiology of the voice disorder. So if you look at these measures, it can tell you this lines up with this disorder. What is a voice range profile? You're getting the highest note possible, the lowest note possible, and then you can do a calculation to obtain the semitone range. You can Google that. Hello, Google, you just say, calculator for semitone range. You put in the highest frequency as well as the lowest one, and it'll calculate those semitones for you. You can also just put a range. It's 450 hertz in between their lowest and their highest note. You want to get their loudest as well as their softest ability to phonate. If they can't phonate softly, you're suspecting some difficulty with the vocal cords being set into vibration. So something maybe like nodules. You want to gather their average pitch, that is the FO, or what we call fundamental frequency, in conversation. So recording the rainbow passage is an easy way to do this. And then you select a chunk of that and then use the average of that to say, what's normal. If a cis male person comes in your office and is speaking at 270 hertz, and you know that female range tends to top out around 250, something's up. Something is not quite right with that person as far as maybe their physiology of how the vocal folds are working for them. If your patient sings, gather a singing example. These are really helpful because you not only get a baseline, but you get to also watch to see how that person sings. Are they using a whole set of different habits and patterns when they sing? You also want to gather cepstral peak prominence and acoustic voice quality index. You could substitute the cepstral, CSID, the cepstral spectral indicator of dysphonia, as well if you have the Pentax equipment, VisiPitch, but you can do that for cheaper as well, and it's just as sensitive of a measure, which I think is really great to making that accessible. And what do you need to gather all that? We'll go into CPP and AVQI in a second, but you need a microphone. So the one I'm using right now is something that you can put on the person's ears and have them talk into that. You could have a handheld one. You just want to make sure it's calibrated, meaning that person comes in, the room is the same, and then you are sure that the decibels being taken match exactly what's coming out of the person. So you can have that calibration done with a sound level meter that's outside, and you can do that calculation prior to any patients coming in. You want to consider the specs on the microphone that you pick. Obviously, if it's challenging and funding is an issue, just use what you have and do the best you can, because I think something is better than nothing always. But if you choose an omnidirectional microphone, it picks up all sounds, and that is different than a cardioid, which only captures sound from one side. So if you have something on your wall or something that makes noise that rattles, like a heater or an air conditioner. Maybe you want to pick a microphone that's cardioid because of that reason. But consider what microphone you're choosing based on the room you're going to be taking these acoustic measurements in. And if you're traveling room to room or place to place, that poses a challenge. So maybe you consider specs because you know you're going to be doing that. The condenser microphone, so this is another spec, is more noise sensitive. It can pick out background noises versus a dynamic. Consider this in your testing environment as well. So you want to pick a microphone that's going to help guide you to pick the most of the patient's voice. As far as software, Pratt is totally free. It is very antiquated looking on their website. If you just Google Pratt, it works. It's clunky because it was not made to be user friendly, but it definitely does the job. VisiPitch, very user friendly, very expensive, also does the job. Voice Evaluate is a brainchild of Liz Grillo, and it's something I believe has a subscription base as well. But this allows, I think, for you to take measures, but then also your patient to take measures at home. So if you need that component, that's a consideration. And I would suggest considering a preamplifier to calibrate. And that just means you have a place for your microphone to plug in outside of your computer, and then you run it through the USB, because you want to be able to account for any variations that might occur. If you just have the microphone plugged directly into your computer, you don't have the control to make sure that the microphone's not clipping whenever it gets too loud. When it clips that intensity, you're not going to get the robust measure that you need to actually accurately evaluate your patient. And we're going to go into CPP and ABQI in a second. But before that, aerodynamic assessment. Maybe this is something you've never done before. I'm not sure. It's a quantitative measurement. It can determine if the vocal folds are vibrating efficiently using airflow, which is really important when you're determining if voice therapy is appropriate for your patient. You know, is airflow an issue? Or is it purely an issue of the valving of the vocal cords? So sometimes a patient's really appropriate for this measure because you at least know their respiratory system is working well. It is a measurement of airflow and air pressure. You can take the S to Z ratio. This is less sensitive, but it still provides data. I attended a lecture a long time ago about, don't throw S to Z ratio out with the bathwater, like the baby out with the bathwater. And that kind of always stuck with me because I thought, well, that's interesting because as we improve on our ability to assess and we have these new ways to take data, some of these older measures, original ones, are still helpful because it's kind of phonatory too. You're taking maximum phonation time in a way with the Z. And you're seeing how the person performs when they really go as long as they can, which gives you data as well. You can find something called the phonation quotient and the estimated mean flow rate, which are more of these stranger voice therapy things that we're going to go into detail in just a moment as well, because maybe those are new terms for you. What you might need. On the higher end of the cost spectrum is the phonatory aerodynamic system, or the PASS. It comes from Pentax, and it's something you calibrate frequently. It's got a lot of components. It tells you a lot of things, and research labs use it pretty frequently. In the real world, not exactly what you need to be taking with every patient, but you could. They use a pneumotachograph. As far as a low-cost system, you could use this article I'm about to share with you from 1984. Grab a digital spirometer off of Amazon, get a timer. We all have one on our phones. Oops. And that's what you need to take. So we'll go into how to take that in just a second. So back to acoustics. There's two stranger things that are newer that I just want you to get more familiar with. And one of those is CPP. It is Cepstral peak prominence. It's an indicator of dysphonia. It's a measure that doesn't rely on fundamental frequency, which is really important when a person comes into you sounding like this, because this doesn't have a good way to have frequency. It's not going to show up on your prat very easily because there's no vibratory movement that's periodic in the vocal cord tissue. What you need to know about CPP, the bigger the peak, the better the voice. So if you have a measure, there's a norm, it's normed in a couple languages, but like 10 is a good norm as far as English goes. Above 10 should be pretty normophonic, sounds pretty normal. Less than 10, closer to 8, 7, or 6, you're looking at something really disturbance in the voice. And it creates two things. Oh, that should say AWAN, AWAN, sorry. Cepstral Spectral Index of Dysphonia with that Pentax software. And then Urimarin, the Acoustic Voice Quality Index. So either one of those measures is great because it includes cepstral peak prominence. And maybe you're wondering what happened to jitter and shimmer. Maybe that's something you are really familiar with using, as well as noise to harmonic ratio. So NHR is a lot of times what that is shortened to. All three of those things, jitter, shimmer, and NHR, they've frequently been used for acoustic analysis, but they rely on tracking changes in the fundamental frequency. So if you have a fundamental frequency, cool, those measures tell you something. But if a person doesn't, this is going to encompass that, which is really helpful. As the voice becomes rougher and breathier, it becomes less periodic and therefore harder to establish a fundamental frequency. And if you were really wanting to check on the science on this, you obtain CPP by calculating using a Fourier transform of the voice spectrum. So the sound signal, they reverse it, and then it shows this peak. What is AVQI? Acoustic Voice Quality Index. This is another one of those acoustic measures. Cool thing is it contains cepstral peak prominence, a smoothed cepstral peak prominence. And here's an example on this slide where you can see this person's smoothed cepstral peak prominence is 13.86, I believe. And that looks pretty normophonic. That's pretty much above 10. But I'm sorry, AVQI considers jitter and shimmer and noise to harmonic ratio. You can see down here, part of those are included within this measure, this number. But this person's AVQI is 3.20. And this person was tested in English, so the norm is set here, where if that black arrow right there was in the green, you'd have a pretty normophonic voice. But in this case, the cepstral peak prominence doesn't necessarily reflect everything that's disordered about the voice, and this person has what's looking like a milder dysphonia with this AVQI of this score. The cool thing is you can get this by recording the rainbow passage, just the first sentence, and then a sustained vowel. You just have them sustain ah. You gather 3 seconds of that ah, the first sentence of the rainbow passage, and you put it in together to get AVQI. All right. Y'all still with me? The phonation quotient. So this is back to those aerodynamic measures. This is from an article in 1984 from Rao and Beckett. This 1970 article also talks about how to gather this as well. This is a lot of math, so I hate math. I created an Excel document to calculate this for me. All I have to put in is the components to gather it, and it spits it out easily, where I don't have to do that every time. But phonation quotient is a measure of glottic efficiency, because if you are looking at the slideshow today and thinking, why do I need to gather this? What's the point? How is it going to help me? Well, it'll help you back up your diagnosis of an imbalance or balance between phonation and respiration. And if you have higher numbers on this, it is going to suggest an insufficiency in glottic function. Not necessarily respiratory function, but the ability for the vocal cords to work the way they're supposed to. So this helps back that information up. If you have lower rates, this might signal an hyperfunction of the glottis where things are closing. And again, it's not functioning very well, but things are overactive as they're being created when someone is phonating and talking or singing. And this is the formula to find phonation quotient. So you get your answer, this PQ, if you take their vital capacity, which is VC, and you divide that by their maximum phonation time. And earlier, if you did S to Z ratio, maybe you gathered a maximum phonation time. Does it have to be on Z? Does it have to be on A? Look at what you were able to gather. The other aerodynamic measure that's easy to get, again, from this 84 article from Round Beckett, is estimated mean flow rate. It is a measure of glottic efficiency as well. And it's a measure of airflow through the glottis during sound production, during phonation. And if you have higher rates on this one as well, insufficiency of the glottic function. Lower rates, you're going to suggest hyperfunction of the glottis. And here's how you find estimated mean flow rate. So you're going to take 77, that number, and you're going to add that to your phonation quotient that you found earlier, multiplied by 2.36. And that's going to give you EMFR. And it gives you some norms in this article as well. And you can use those as your comparison for norms, like we talked about earlier in the lecture. Or you can use it as a baseline measure and then measure it after a few sessions of voice therapy to see if there's some sort of improvement. All right, stimulability testing. We have this to talk about, and then goals and education, and then we'll go to part 2. This is the direction your therapy intervention takes. And maybe you think you have this knowledge of, voice therapy techniques and that maybe one works for everybody, but that's usually not the case. You should really base how your goals are being made and your trajectory of therapy frequency and timing on how your patient responds to what you're having them do with their voice. You want to know what the issue is. You want to know if they get relief from anything you're trying at the evaluation, whether that's lip trills, whether that's yawn sign, whether that's inhalation phonation, whether that's talking and vocal fry, whether it's talking with resonant voice. You can try different things as far as maneuvers from the outside. So see if you can target those extrinsic laryngeal muscles. And then you want to know if you're attempting to educate and promote healing prior to surgery. Maybe they're not able to sound better based on your stimulability, but they're going in next week to get that polyp removed. So you're going to talk about what they want to do after their rest period is done for wound healing. What are they going to do to help get them back to phonation? And then, do they sound less dysphonic after trying a technique? Do they sound less dysphonic to you? What about to themselves? Some patients, you want to make sure if they're actually hearing what you hear. And sometimes I'll play some examples and I'll say, what do you hear? To see if they hear roughness or to see if they hear normal sounding voice. Because sometimes I'm just not sure if I'm hearing what they're hearing. And that's important because if you're tracking progress as the clinician and you and the patient both have different definitions of dysphonia, how are you going to come up with goals and how are you going to know if you're progressing towards those goals? So this is a copy and paste from a redacted evaluation of mine for what I did for a patient. We used Nelson Roy's reposturing, which we'll talk about in a minute, and straw phonation. We tried those, and I always indicate that, some things, if they were just a total fail, I need to know that they didn't work, really to remind myself for next time, or to any clinician that might see that patient after. But tongue out raspberries, like that actually, were most successful and improved what? I define that coordination of phonation and respiration when used as therapeutic probes. Then I say how I educated, and I also say if I gave some skilled demonstration, and then could they do it? They could complete to achieve a perceptually normal voice. And this was recorded and played back to the patient. So I write down what we actually did together. A dramatic improvement. Sometimes I say a slight improvement or an intermittent improvement. I'm specific. And voice quality was noted immediately. So if I'm reading this back, I'm going, wow, this person really had a 180 difference in this. Following 60 seconds, that was probably a guess, of these tongue out raspberries, and voice was normal 90% of the time as the evaluation ended that day. So that's pretty good. Cool. We are right on time. Goal formation and education. You want to determine goals. What does the patient have a deficit in? Is it quality of life? Is it the ability to speak loud? Is it sounding clear? Is it feeling good about their own voice? And that's going to help you determine what you want their goal to be. You need their input for that. You don't just need to be determining goals for them without seeing what they want to achieve. Ask them when they are in your office, you want to know why they're there. What are they there to achieve? Did they just come to make sure they don't have cancer? And there's nothing growing weirdly in the larynx? And are they happy with that? If they are, they're not appropriate for voice therapy. They don't have any goals. Their goal was met. They feel better knowing that they don't have something growing in there. This is important and challenging because when you have to be the bearer of bad news, what's realistic for the patient if they have a lot of vocal cord scarring and they have a pretty irregular glottic closure, maybe really challenging for you to say you're going to expect pretty decent recovery. We can't ever promise outcomes at all. But with good confidence for the patient we looked at just a second ago with that excerpt, prognosis was pretty good realistically for that person. But if stimulability trials really didn't yield a whole lot of change in the voice, probably I would have some hesitation about meeting goals that were specific to getting the person to sound normophonic again. Maybe goals just to help them feel better about their voice, cope with the changes that they've experienced, come to terms with that. Those might be more realistic goals. And then this, do they need to be referred back to ENT prior to beginning the intervention? Tough, because if you see a really inflamed larynx and you know it's got to be a team treat because they're going to need medical management of the irritation that you're seeing, thick mucus, swollen vocal cords, and then nothing is getting them better as far as your stimulability, that may be very appropriate to just refer them back. So this is just a couple examples of a long-term goal and then some short-term goals to try and meet that. I have 2 blogs on atempovoicecenter.com that list just kind of not necessarily a goal bank that you'd want to copy and paste, but something that you could refer to and look at and modify based on the needs of your patients. So there these are. And now we're going to go into part 2, which is indirect and direct voice treatments. So this might be a review on some of these, but you may learn some new things about what's coming out in current literature about the things that actually work, when you might want to use them, and how long those improvements last. Direct voice therapy. This is something that you are having the patient do with their voice, specifically to make it sound different. And this encompasses resonant voice therapy, also known as Lee-Sack-Madsen, stretch and flow, also known as confidential flow, flow voice, flow phonation, those types of approaches. Semi-occluded vocal tract exercises. So SOVTEs for short. Vocal function exercises. That is a specific regimen of exercises that you have a patient do kind of at a prescriptive administration twice a day, usually. Phonatory resistance exercises. So that's things like LSVT and Forte. Conversation training therapy. That's newer on the docket. Has to do with some tenets that you want to include in every session, maybe a little bit different recipe every time, but we'll talk about that in a moment. And manual techniques, which include circumlaryngeal massage, laryngeal reposturing, manual therapy, and not as much myofascial release as it was a few years ago. Just research has continued to move on. So I'm going to go into just a brief description of each of these direct treatments to review for you or to maybe teach you something you didn't know before. This has roots with Mark Madsen and Arthur Lessig. Katie Bertolini Abbott packaged this up for replicable training. So and Joe Stemple has a program for this too, or kind of a basis in roots. When you look at applicability, you can see what Kitty did to make this measurable and make it easier to administer to patients, especially from clinicians who may not do voice therapy all the time. So I think what she did was really helpful because of that. You're using a forward-focused hum. With a relaxed larynx. You're using this to help increase efficiency of breath, vocal fold vibrations, and resonance all together. So you're really trying to obtain a nice balance between those. Among those. And then to decrease strain, if people are complaining of vocal fatigue, or if you're hearing a really strained voice, you know they're not using enough airflow. Is something they can use tactile sensations to rebalance those systems. Also, I used this recently with a patient as I thought about what I was doing in the moment to establish awareness of sound production. So I don't think she was aware of how much she was imbalanced. She had a lot of hyperfunction of the larynx squeezing, less breath flow being used. And I went here for just a moment and I said, let's just do this. And I want you to tell me what you feel. And a lot of people don't like doing that because it's something they're not familiar with. Well, my voice is my voice. They haven't thought about exactly what components make it up and how you can change and manipulate those components. The stretch and flow has roots with Ed Stone and Robert Castile, and it is the only approach to reduce laryngeal tension that actually eliminates voice initially, but keeps articulation and breath intact, and then adds voice again later slowly. This is neat because you sometimes need to take things out of the equation to improve that self-awareness, to really let somebody know, yeah, you're not using airflow to talk on. And sometimes that can only be realized by the patient if you take the voicing away, but you keep everything else. So they can start to feel, wow, I can actually identify that breath. What's your base on it? Just things you want to make sure you're including. Airflow at the lips, where you feel something tactile. Parted vocal folds, so things are open. You're not getting any sound there, and it's overly breathy. It's not functional as far as a voice. You couldn't do this all the time, even if you added voice to it. It's not functional, and that might be a turnoff for a lot of people because you might hear them tell you, well, I'm not going to be using that voice on a daily basis, so I don't want to practice it because it feels weird and sounds like I'm on drugs. We use this to reduce vocal fold collisions and to decrease strain, and then to retrain compensation of laryngeal hyperfunction. So if that has been a compensation for someone, this is a really nice approach. This can also be done pretty easily when you suspect spasmodic dysphonia or even tremor. This is a helpful thing sometimes because you're adding a lot more breath. But you usually find some sort of limit on the spasmodic dysphonia patient because they can't then transfer that to more words. Maybe can get to the word level. Then as soon as they start adding more words onto their utterance, you find that they have a breakdown. But trying to establish or retrain airflow, decrease hyperfunction of the larynx is when you'd want to use it. Semi-occluded vocal tract exercises. These have roots in research from Ingo Tietze, Joe Stemple, and many others. Technically, resonant voice is a semi-occluded vocal tract exercise, but it just has a different program that's just more lined out. But all of these things create a more balanced larynx on the inside because they're utilizing back pressure. And that is airflow that is trapped in the throat. And it helps balance everything because it keeps the vocal folds from not colliding as hard. So I tell patients, no matter how much you're relaxing in your brain or you're self-aware of your body, if you're doing one of these exercises, you're doing something physical to change how your vocal cords are vibrating. And it's not just something you're thinking about doing, it's actually being physically done. You would use this to help increase efficiency of breath, to decrease strain or fatigue. It goes back to wanting to find a proper balance of respiration, phonation, and resonating cavities. And so if you needed a goal to decrease hyperfunction or like decrease vocal pain, give them a warm up to rebalance their vocal subsystems as kind of a preparatory thing, or to rebalance them after they've done some voice use as a cool down, these are your go-to. There's a ton of types. I won't spend a whole lot of time going through all of these, but straw phonation in a cup, also known as lax vox. The cup needs to have liquid in it. Semi-occluded ooh, that's going to be blowfish, a mouth posture kind of like this, where you have a tiny little hole in your lips, but nothing comes out your nose. Tongue trills, or tongue out, and lip trills. Cup phonation, where you're poking the hole in the bottom of a cup and putting that entire cup over your mouth, and having that hole a certain size. Wave in a cave, Marcy Rosenberg, with this clever name because you're making a cave with your hands and you're creating complete, almost, occlusion of your mouth. And cup phonation and wave in a cave allow a person to sing. So if you recognize that semi-occluded vocal tract is something that benefits your patient, but they sing, suggest this in place of a warm-up, potentially. Phonemes, inherently, M, N, and ing, where the base of the tongue is up against the soft palate. Those are going to be inherently semi-occluded. Nandu has recently done an article, a research article about modified hum. So putting the fingers against the nostrils almost all the way. So something like that. Kind of pleasant. I mean, just personally, it's like, well, that's something I didn't grow up doing, and that elicits a nice response, I think, in the larynx. Phonemes, E and U, and kazoo phonation, because you're using vocal cords to use a kazoo. Sometimes that's a good distraction for a patient if they're so used to thinking phonation is one way. They may find it challenging to do that on command. But if you give them a distraction in their hand and they're just like the straw and they're trying something new and novel, the brain tends to work a little differently sometimes, and those connections can happen where there's a balanced vocal sound coming out. Vocal function exercises. So the article that I have down here at the bottom really talks specifically about more applicability of vocal function exercises. It's not, what is this, but it's more of what is the mechanism of change? And roots in research in these specifically come from Joe Stemple and his lots and lots and lots of research assistants. The base of this, because the mechanism of change historically is semi-occluded vocal tract, you get the same thing. You get back pressure from inertive reactants that helps the vocal folds not collide as hard for injury prevention and rehabilitation for this. The semi-occluded vocal tract makes vocalization more efficient and balanced, and you can use that to increase efficiency of breath, vocal fold vibrations, and resonance to decrease strain, but also to improve stamina. So if I have a patient who has vocal cord paresis, potentially, and they are really complaining of fatiguing and just getting really tired, or they can't hold the notes out as long as they used to be able to, this is more of a gym workout that I may give them versus just saying, do some random times of the day, some bubbles in a cup or some straw phonation. You would give this with an intention of taxing the system to a degree because you're asking them to sustain sounds for a long period of time. You have them do it twice per day, and it just consists of 4 exercises. You're having them do a mid-range as long as they can hold that out. It's very nasal. It's to be done without strain. So if you have your patient, you're going to need to use maybe one of the approaches from above to help rebalance that. Then you can apply this. So sometimes this is an intermediate level in my mind of giving to a patient if they seem well aware of what their body's doing. Maybe they have mild symptoms, I'm giving them this, but I usually don't start this out with somebody who really has poor coordination, unless I have 1 or 2 sessions, one right after the other to really train them and introduce this well. Then you're doing semi-occluded vocal tract for a glide. You're going to glide from low to high. So something like blowfish or tongue trills, as long as it's semi-occluded. And then you're coming back down. Or then you're choosing 5 different notes. And you're getting each one of those notes its own as long as possible time with, again, that semi-occluded vocal tract exercise of choice. So if I started here, it would be and you'd hold that out as long as possible and do the same thing for those notes. They increase in pitch, so the vocal cords get a little bit longer each time. And regardless of vocal cord size, you want to do the same pattern. But if your vocal cords in your patient are larger, so if they are cis male or if they are a trans man and they've gotten a whole lot of testosterone in the past, they're able to access these lower notes. So something like this as the base, you can have them start there. Some of my trans individuals, non-binary individuals, I'll modify to somewhere in between those to have those 5 notes completed comfortably. That's really what you're aiming for. Can they do it comfortably? And I think, oops, I'm going to go back. I think the cool thing here is when that study that's listed down here was done, they modified everything to ah as the phoneme instead of doing the semi-occluded. And what they found was that it resulted in a totally different outcome for patients. It actually made their maximum phonation times longer. But the semi-occluded vocal tract made the vocalization more efficient and more balanced, so not necessarily longer. So you can consider those outcomes from this 2019 study to say, why am I administering vocal function exercises for my patient specifically? And is that in line with their goals? Okay, phonatory resistance training. So there's a couple of different ways to go about this. Fox and Ramig with LSVT, Samantha Allenderry, Speak Out, and then Edie Hapner and Aaron Ziegler with their more recent Forte papers and body of research. Cynthia Fox and Lorraine with LSVT, that is administered in a different way. It's more frequent as far as clinician intervention, and it's specifically studied in Parkinson's patients. Ellenderry's is a little bit different, less frequent as far as clinician based, but all of these include repetitive things daily. They just differ in how much the clinician is involved in that. And then Hapner and Ziegler really looked at specifically presbyphonia. So just kind of age-related vocal cord bowing that impairs and prohibits people from sounding the way they want to, but it's not necessarily because of a pathology like a lesion or a paralysis. But the base is exuberant voice exercises, loud, strong, those types of words, in a replicated almost daily administration. So you do see some days when there's a rest day. You can use these for Parkinson's. You can use these for glottic insufficiency, for patients who have poor respiratory drive, and then I like to use this in my notes because it makes me sound smart. Poor respiratory phonatory coupling. Like basically you're just trying to improve how they work together, but save that for later and maybe modify it to something, but also possibly for unilateral vocal cord paralysis or unilateral vocal fold paralysis. That's what that stands for, the UVFP. And that's being studied currently. So they're looking at what you might want to do in that situation. Before Forte came out, I was using vocal function exercises for glottic insufficiency, but I was using the semi-occluded component. So I wasn't getting a whole lot of improvement in patients and thinking, man, I wish there was something that was not quite LSVT, but not quite vocal function exercises to really give to these highly cognitively abled patients to be able to do that's improving. And then Forte was there. And again, 3 times per week, clinician intervention for Speak Out, 4 times a week for LSVT clinician, but then they're still doing practices, I think 2 sets at home every day, 1 set on the days they see the clinician, and then 6 days a week independently with check-ins. That's up to a couple weeks actually for Forte. That's the cool thing about that. You can make sure they know what they're doing and really send them for a couple weeks on their own without a check-in unless they feel they need it or you feel that they need it to be able to have them attend. It's really hard for people, humans, to attend voice therapy. It's a far drive. Maybe they don't have time. Maybe they don't want to. But if they can have something that they can try and they're motivated to do that on their own and they'll do it, it's going to result in an outcome that's good, usually. So this is a newer research-based protocol. It's kind of a protocol. And this is specifically Jackie Garner-Schmidt and Amanda Gillespie. And this is something that's different. All the ones we've talked about before are kind of these hierarchy things that you're following. A baseline sound, you're modifying it, and then you're moving it into connected speech. This is not a top-down. This is more of a Venn diagram of we're meeting in the middle at a certain goal point, and we're adding parts of these tenets to what we want to achieve as the outcome. You have the base here in the awareness of how voice is made. So this follows no traditional hierarchy. It does use motor learning theory, but it uses it in spontaneous context where the other approaches do appeal and utilize motor learning theory. This can be challenging for less experienced SLPs who may not use voice techniques on every patient or with enough frequency to have that kind of upper level cognitive thing going on to analyze what you're doing as you're doing it, plus the patient rapport and things. It's hard when it's all going on at one time. Those SLPs may have difficulty because it's really on them to reinforce, imitate, and model different voice targets during a conversation, which takes some practice. It's like acting. It uses 6 tenets. So this is this tenet word I was talking about. Hopefully this clears up that confusion if there was any. Clear speech. That word combo, that target, you're asking them literally to use clear speech when they talk. Using training or asking them to verify auditory, what they hear, kinesthetic, what they feel, awareness, rapport building, so finding a way to banter back and forth with them, meet them where they're at, kind of mirror their personality to say, you know, you can get with this and make this really applicable to them specifically. Working on negative practice. It's not like negative practice isn't present in resonant voice therapy or stretch and flow, because we can use those pretty often in those situations. But for this, you're actually wanting to have them change to something that's less coordinated and then change right back to something that's more coordinated and maybe something that's even more forward and go back and forth between those things as you're having them cue themselves. So what I did there was I went from a vocal fry voice, really low respiratory drive, to something more balanced, something that was really heavily balanced and forward focused resonant voice. Basic training gestures. That is simply using something to kickstart them. That could be a hum, used as yes. So something like this. And then having them do a whole lot of listening to you blab on about what you bought at the grocery store earlier. And then they're just affirming, and then that takes them to that conversation voice, that new voice that they're using. And then maybe you cue them, okay, go back to that old voice or go back to that strained voice. You know, this uses the idea of an old and a new voice in those sessions. And prosody, how they're varying pitch and length of phrasing. Is it something they can coordinate like this that helps them? And then they can shorten that to sound more normal. That type of thing. It's a conversation-based model. There are no steps. And that may be scary too, because you're thinking, oh no, this is so very different from what I've learned in the past or what I've had some handouts that I found at my location and I'm able to read this. It's just a connected whole framework that I like really to visualize that kind of pie where in the middle you have where you're headed. You have this balanced voice, but you have these little slices of things, these tenets that go into it. And sometimes one of those slices might be the majority of what that person is doing or what you're focusing on in that specific conversation in that session. But work on that because you can develop those therapeutic skills to elicit patient awareness and keep that conversation fluency going. And that's going to benefit you when you're using this. They have a really good MedBridge, and I mean Jackie and Amanda, they have a really good MedBridge course where they're discussing the outcomes. So specific to how that is being carried over and if those people are maintaining improvement months and months and months after. So I think you'll find the research surprising in that even though this is not a hierarchy, you're getting people getting better faster and staying better longer, according to the research, which is really, it kind of blows my mind because the administration is a little different. So manual techniques. These are different approaches that are done on the outside. So things to target the extrinsic laryngeal muscles or laryngeal posture. There are different approaches that we'll discuss in a moment. usually used to alleviate pain. I will use these often in patients who have presbyphonia, or we also call that, not presbyphonia, sorry, mutational falsetto. And this can be done to help somebody realize that their larynx is in a position that might take a whole lot of effort to maintain. And I just mean like maybe a laryngeal posture really high in the neck. And that can be extremely eye-opening to that person who has gone through puberty. Their vocal cords are bigger, their larynx is bigger. It's going to feel different to make noise, and it may feel really, really strange. But that can be a really helpful thing to do to modify, prevent and prohibit the larynx from moving the way it was, and then having them phonate. Also to restore function. If people have muscle tension dysphonia that's developed from laryngitis, you can absolutely use this as a trial to see if that helps them identify and be able to produce and then reproduce really coordinated vocalizations. So circumlaryngeal massage, research by Decan corrects laryngeal position, and by correcting, you're either pulling up or you're kind of pulling down to give some more flexibility in that by doing these circular movements. And you can vary the pressure, you can vary the positioning of your fingers or the patient's fingers, but you're aiming to relax, re-posture to a degree, the laryngeal and cervical muscles to improve voice quality. And this is if you read his articles, it's very specific to muscle tension dysphonia and puberphonia, or that mutational falsetto. Laryngeal reposturing. This is Nelson Roy. More recently, he defined things kind of like Kitty did with resonant voice therapy to name them pushback, pull down, and the combo maneuver. So the pushback is just pushing back directly on the hyoid bone and having them phonate. And if their larynx is high and if they're resisting muscularly, and that's what's causing the muscle tension dysphonia, that'll help. Oh, my voice is there. That'll help them recognize and identify that. Pull down. You're putting your fingers in the thyrohyoid space and kind of wiggling and pulling down, keeping that larynx from rising too much. And then combination is actually having your whole hand kind of here in those thyroid hyoid spaces, and then with this part of the finger right on the hyoid bone, and you're kind of just prohibiting any raising. You start them on, again, hierarchy. If you can get that sounding good. 2. So it's like stretch and flow. Counting, then combine numbers 2, 3, 2, 3, 4, 5. Okay, so if they do that, lower it back down to like 2, 3, 4, where it's one breath per phrase, or sorry, one phonatory, one articulatory choice per breath phrase. And then you can work to having them do a couple per breath, 1, 2, 3, 4, 5, 6, 7, and then having them go to conversation. Then you kind of slowly fade your hand out of there. Which I think is it's really impressive that somebody can do that, and then the patient gets very aware very quickly something is very different about their voice and they can hear it again. And manual therapy. So this used to be myofascial release, where we thought that you were massaging and holding these trigger points where things would release, and once you got to a certain threshold, and that release would take over and the voice would be really normal again. But because of Nelson Roy and others, there have been some new studies that have been completed, and really they show brain changes. So there's something about manual therapy that changes the neural regions of the brain and forces them to re-coordinate, and it disrupts those dysfunctional neural patterns that we see present with patients who have this really, what we call recalcitrant, or like it's really hard to get rid of, muscle tension dysphonia. And that the consideration is that primary muscle tension dysphonia is present as a result of overactivation of those certain neural regions of the brain that results in a disordered voice, and that treatment in the periphery. So things that you're doing to the body, whether you're kind of just holding steady pressure or maybe just holding something moved, maybe larynx held up. Fritz's course is really great to look at all of those things. And when that's done for a certain period of time, it really appeared based on these brain scans to disrupt and eventually deactivate those weird brain patterns. So there's something to consider about manual therapy. I think it should be used in conjunction with other things. I don't think it would necessarily be a standalone thing, but it could, depending on how the patient reacted. But it's the power of touch. It really is. All right. So indirect voice therapy. So we went through all that direct, and this article right here at the bottom, here's Jackie Gardner-Schmidt again, and she and her team looked at, Clark Rosen's on this too, really looking at what makes up voice therapy, how to quantify these parts. Indirect is what we're about to talk about. Direct meaning those things that you're having the patients do to directly influence how they sound with how they're using their voice in the moment of vocalization, in the moment of phonation. So this includes, but isn't limited to, I think, anatomy, voice production physiology, whole mind and body awareness, vocal conservation or vocal rest, LPR, so that is reflux, laryngopharyngeal reflux, and how diet modification can influence the laryngeal environment. Hydration, we'll talk about systemic and topical. Counseling, up to the point of what you feel comfortable doing or determining if you need to refer out to a licensed professional counselor or a CBT therapist. Stretches and relaxation, environmental modifications, homework preparation. So looking at that list, it's like, wow, that's a whole lot that goes into the indirect components of things. And I'll go back to that slide because I really feel like I get emails from people asking, what can I do if somebody hasn't had videostroboscopy? I can't get them in. The wait's long, or the ENT doesn't do it, or they can't travel, or our facility doesn't have the availability and the machines to do that. These are a lot of things a person can do as far as counseling goes to a degree, to the best of their ability in that time period while you're waiting for that videostroboscopy to be completed. So in this component, this could take up an entire voice therapy session, or it can just be a small chunk. You would want to have discussions on vocal anatomy and laryngeal structures, respiration, phonation, resonance. This handout is free on my website. If you like how it looks, just go there and you can sign up for the email list, and this is part of that free library that you have access to. But you would want to talk about how vocal folds move to control for pitch and loudness, just so they understand. When vocal cords are in a long, lengthier position, what does that sound like? When I close them completely and hold my breath, what does that do to my voice? So it really helps with awareness of that, which should be the basis before you begin any behavioral intervention, in my opinion. Just you have to assess their awareness. Understanding how breath plays a role in sound production, how it keeps the vocal folds vibrating in these really consistent, replicable cycles. What about whole mind and body awareness? So there's some more Stranger Things pictures. Awakening awareness with discovery for the person, or really trying to determine how much they are aware just at rest, not doing anything, but like, what are their awarenesses of maybe when they watch other people on video or watch you breathe and vocalize, and then applying that to themselves and their own vocal production. Having them do things they likely haven't done since they were children. Ooh, ooh, ooh. Doing these kid noises. You know, if you're a parent or if you are a teacher, if you hang around kids a lot, they are making the weirdest noises. Like just I have two kids and they constantly make me laugh. And I guess I don't know if it's just because of my line of work, but I'm like, you would never catch an adult person making that sound. And I don't know why they're in there doing it. But you can cue them to allow sounds to be produced in a different way. You know, have them talk or phonate on the inhale. Have them add words to that. Hello, how are you? Hello, how are you? And then have them do it on the breath out and see if that will help disrupt some of those patterns that are maladaptive. It is weird, but it works. Have them slow down breathing, speed it up. Have them slow down phonation, speed it up. Have them stand in front of a mirror and do some things to actually like kind of improv exercises where they may do some really slow motions and see what they actually look like as they do that. Some people have really low awareness of how they move and where they are in time and space. So I included this picture here because when we talk about vocal conservation, we really have to discuss with our patients and not assume that they know what vocal rest means, because I don't even know what it means. It could mean so many multiple things. It could mean lessening vocal intensity. So how loud are you talking? Just talk less loudly. That's vocal rest, or could be. The frequency of how much you are vocalizing. So not in like pitch, but how much are you using your voice? Are you working 5 days at your teaching job and maybe you could work 3? Or you could take Wednesday off and you could work Thursday, Friday, Saturday at your hair salon and you're talking to your clients over the blow dryers. And so you're having that break in between and you're not talking as many. Or maybe you cancel clients. Maybe you only see 3 a day instead of 5 for a little while. And I educate people in this way and say it's like a mixing board where if you can, over a period of time, modify a couple of things very slightly and let that play out, you're likely going to have some sort of market improvement there. Some people identify vocal rest as really strict vocal abstinence. So they're literally not talking. They're on silence, tape over the mouth kind of idea where they're not even throat clearing or coughing. And in cases like vocal hemorrhage, that's what you got to do. Maybe for a week, maybe for 2. So use that. Use these knobs of on this mixing board to help you find out where you and your patient agree on what vocal rest really truly is. So with this, you will likely need to be approaching this with either an ENT or GI physician, but we can't write prescriptions. We can only recommend to modify diet. So this is something you want to talk with the doctor about and determine how much you think this is really influencing the person's voice disorder. Could be the only thing you think is influencing it based on what they're saying. And you can educate them on foods to avoid, foods to use. There was a study, I should have included it here, but it looked at people taking proton pump inhibitors, so like Nexium and Prilosec, acid reducer medications, versus people with the same symptoms just doing the diet and exercise modifications. The people doing those 2 things made more of an improvement, had less symptoms than the people taking the drug alone. So there's something really inherently difficult about that because it's not as easy as taking a pill would be, but there is research to suggest that's going to make a really big difference. So that's kind of a hard counseling thing. Explaining how drugs work. What's the difference between a proton pump inhibitor and an H2 blocker? What about sodium alginate? So proton pump inhibitors are things like Nexium, Prilosec, Prevacid. They make the acid pumps make less acid. So they're usually taken on a 24-hour basis. It's not an immediate symptom relief. It's more of a preventative, and sometimes people get on these and it doesn't help at all. H2 blockers can neutralize acid, and sodium alginate can create a raft of goo. It's kind of gross at the top of the stomach, bottom of the lower esophageal sphincter, and keep reflux events from happening. So it does nothing to neutralize, although it does have a demulcent. So like when they swallow it, it feels good and it kind of can soothe that tissue if it's irritated. But it's also not FDA cleared in America like it is in other countries. So kind of interesting discussion we want to have with your patients. But the research is there. They use it on neonatal babies to manage their reflux if you go to PubMed and read the studies. So kind of interesting. And then education on surgeries, if that's applicable, things they could consider, how life-changing a surgery for reflux might be. So hydration is another part of indirect voice therapy. Systemic, meaning what you are drinking. So food, liquid, things that you're consuming, like fruit is really high in liquid. So that's going to improve your systemic hydration. And it's going to keep your body systems lubricated, and theoretically your vocal folds lubricated as well. When you are dehydrated and you drink alcohol or you take medication that makes you really dehydrated, or you stay up late and you don't rest well, you hear it in your voice usually. And that's because the tissues can't move well when they're dry. But it lacks sufficient evidence that clearly links hydration to the voice. Like we know, that's why we know it has an effect. We suggest things like 8 glasses a day or half your body weight in ounces, but true evidence basis for this, it's really challenging to say, here's exactly how the body uses this drink to make my vocal cords work better. On the other hand, topical hydration, so applying hydration to the vocal folds from the surface, inhaling things, has a couple research studies to really connect this to less vocal effort. So people able to vocalize more freely as far as how it feels to speak or to sing. And Christine Tanner, and here's Nelson Roy again, and a couple of articles actually showing improved vocal ease when looking at nebulizing 0.9% isotonic saline. And this is because perceived phonatory effort. So they basically, how fancy is that? They asked people, how easy does it feel to sing? And the people rated that. They dehydrated them first. They had them all breathe like Sahara grade dry air in oxygen masks. And then they had them vocalize, and then they had them each group administer the 0.9% isotonic saline. I think they did hypertonic saline, and then they did sterile water. And the people who did the nebulized isotonic saline, the 0.9%, the effects of that ease were well above anybody else in the study, and the effects lasted nearly 2 hours. So we don't know a whole lot about dosing on that because she didn't continue those studies with that, but you can kind of trial and error, and that's why talking with a physician is really helpful for this, because saline's not a drug necessarily, but you're asking your patient to administer this internally, so if they have asthma, that could trigger something. So you want to run this by a doctor and say, yes, you can get this on Amazon. Yes, you can get this online, but if you don't talk to a doctor first, that probably wouldn't be wise. You want to kind of make sure that you don't have anything that might be worsened or exacerbated if you're administering that. A lot of voice therapy is listening. People want to be validated in what they're experiencing with their voice change or their voice loss. And we are those people. We are those caretakers. That's why we do this for a living, why we're called to this usually. So we can affirm and validate what somebody is going through by practicing trauma-informed care. We can recognize the trauma potential, something that's yet to be seen on the horizon. They just got a diagnosis of vocal nodules. What's going to come after this? and letting them know that however they react to this, it is normal. And letting them know that you offer a safe space for them to be listened to in a way that they may not be able to talk to other people about it. And they may not be able to talk to anybody about it because their career is on the line and they can't talk about the vocal injury. So it may be very much on the down low. This is a tough one because asking a person to take responsibility and ownership may take multiple voice therapists. I get a lot of patients who I'm their second or I'm their third voice therapist. And then I also get people disappearing off my schedule. So then I think I am the first. I am the first and they've gone elsewhere. They've flown the coop. But usually it takes, for some personality types, multiple voice therapists telling them the same thing, or maybe the same thing in a different way, until maybe either they've heard it enough times or they're ready to accept that in their life stage, or maybe their personality clicks with the therapist they're with. So try not to take things personally if people just don't show back up. You can call and just let them know, hey, did you want to schedule a follow-up? But if they don't want to come back, they're not going to come back. But once they're at that position to take responsibility for the voice issue and ownership, you can be that person to help support them in that area. Lots of stress and anxiety can cause a voice disorder, depression, as well as follow diagnosis of a voice disorder or something they've been struggling with for a long time. And it's important to understand the family dynamics, especially if you're providing like gender affirming voice care to a minor, or puberphonia or mutational falsetto care for a minor. Their family is still involved in their care, or their caregivers are, because they're a minor. So it's challenging because they get to that age where you're thinking, I can really talk to you like an adult, but I recognize that your brain's not fully formed yet. But I still can validate those things that you're feeling and then encourage their caregivers to do so. And you can set an example there. It's tough with this. I think counseling is really challenging. And suicide prevention, like you've probably dealt with patients who you can tell something is making them very sad, but it's really, really, really impossible to know if someone's considering killing themselves. So I think it's important to provide that openness and that kind of to the point questions. If you sense something or feel like it's appropriate to ask, are you considering self-harm? Ask them, be that safe space, because and remind them, I can't tell anybody what you're telling me. If you want to talk through this, as long as you suspect they're not going to do something, right then. And then if you need to, calling the right people, a licensed social worker, a licensed professional counselor, cognitive behavioral therapist, that kind of thing. Stretches and relaxation build awareness. Can be part of a warm-up vocally for singers, actors, but don't limit it to that. Maybe it's a telemarketer, someone who works in a setup like you see me on right now, and, their butt cheeks end up being asleep by a certain point, or they need to stretch and get out of this hunched over posture, or they're kind of stuck talking like this on the phone. It can be challenging when you're a voice user professionally, in the capacity that's not kind of traditional voice acting or singing. It's everybody, it's teachers too. Explaining what tension is, our vocal cords have tension, just starting from one point at the anterior commissure back to the arytenoid cartilages. Like there's tension there. If one cord lacks tension, you have asymmetry. So you have roughness and hoarseness. It's not all bad. Tension has a place, but when tension is out of balance, there's too much tension, so it's hyperfunctional, then we have a problem. Upper body stretching and posture, negative practice for deactivating muscle tension. You'd want to say, let's tighten everything and let's loosen everything. This is important for people lately because a lot of us are doing Zoom. You see me on Zoom today for this lecture, and I had to consider reducing my background noise today. You want to optimize for virtual interfaces. You see me on a microphone here, and then I also have these headphones where I can actually hear myself through these, so I know not to try and talk into the computer, where then over these hours of lecturing, I will get vocally fatigued likely. So talking about that with your patient, what they're experiencing, and then saying, well, maybe you can try using some noise canceling headphones or setting things up through a way where you can monitor yourself a lot easier for how loud you are. Use of sound generating devices, clapping, lights, that kind of thing. Discussion of expectations for what you want them to do. They may come back and say, I'm not going to do that. And you have to say, okay, let's talk about what you can do, and then meet them where they're at. I think you would rather that, because I would rather that. They're doing some of the exercises versus none at all if they feel that they can't do what you've expected. So showing that leeway, but then also saying, hey, I would like it. We would know more if you could do it to this degree, but if you can't, just do your best. Modify things in a way that you feel best aligns with that certain voice protocol. And then importance of motor learning when they can practice randomly for a short, really focused period of time. There's a video I like to send people. It's a TED Talk about practice habits of elite athletes. They go to it, whatever the task is or the talent, the skill, they focus on it, they do, and then they rest and they go do something else and they come back to it. So they're not just sitting there over and over and over, the eyes glazing over. And then how long will it take realistically if you've modified that? So if they're only able to do forte 3 days a week because they babysit their grandkids the other days and they just can't. Maybe you educate them, well, on those days that you don't have the grandkids, cool, but maybe you can involve the grandkids and we'll do it together as a team. And I can, we can work on videos and they can do the ahs with you. That's something to consider. So, all right, we have just a little while left. We have about 17 minutes left. These are some case studies. This first study is a 55-year-old female. She has been with some voice issues since about 2 years ago. She coughed and choked at the time of onset and threw up a lot. She's been treated. She's been through the ringer, looks like. She's had antibiotics, she's had steroids, she's had allergy shots, reflux meds. She also had history at the time of the voice change onset. And I think it's important to know if they're willing to share with you what that trauma is, because that helps you as the care provider. But I'm never like, I can't continue to take your case history if you won't tell me what happened. Set that rapport up and help build trust with them. It's interfered with work. She's participated in fewer social activities since the problem began. And I know this because I have on my questions, like intake sheets, I have these yes or no questions, and they are these detailed things. Do I agree with this? I am participating in fewer social activities since the problem began, and then they check it. But it looks really good in your notes because you can say, hey, they're participating in a whole lot less, which is impairing or impacting their quality of life. So conclusion drawn about the impacting of quality of life. There, you can ask them point blank, but this helps if they can answer these things on the intake paperwork. She has a feeling also, feels like food gets stuck when she swallows. How does it sound? Voice breaks. What does she feel? Pain when trying to talk and to breathe. And she has no voice a lot of the time. Here were her medications. And this is how she was hydrating, about 8 ounces of water a day, but she didn't drink alcohol. So that might have been okay. I'm not going to just say, wow, 8 ounces is not enough. That is the first order of business. You're going to hydrate yourself. Because I don't really know that that's not hydrating her well enough. She quit smoking 3 years prior to the onset. So I also don't think that, just looking at the case history, that this is impacting. I'm not expecting to find Rinke's edema based on this history because she quit so long ago. So here was the Videostroboscopy report, and we're going to watch the video. We did rigid. She had asymmetry in her vocal cords. Amplitude was reduced. This is the kicker. Aperiodic 90% of the exam. This tells me that all of these other measures I didn't really get a whole lot of information from because the signal wasn't periodic. And if it wasn't periodic, the machine can't work. So I could see a little bit of a mucosal wave at upper pitches with verbal cues for increased intensity, but she had a pretty incomplete closure. And I was thinking after this strobe, primary muscle tension dysphonia because of what I could see. So let's look together.
Hold that out as long as you can, okay? Good. Now breathe and go easy. Good. Again. Good. And breathe in. And go, hey. That's okay. Come forward one more time. Yeah. And the more weird it feels, the better I'm able to see. Stick your tongue all the way out. Bite real gently with your teeth. And then
So you can see how dysfunctional this exam is. She's really gagging, but it's not a gag to push me out. It's a laryngeal level. And you might look at this and think, oh, there's spasms. It may be spasmodic dysphonia. Is there a tremor? Look at it. It looks off. Look at those false vocal folds squeezing in and getting in the way. Even the louder didn't really make it a whole lot better.
and again, big breath and loud, loud, loud.
Just seemed to be more strained when she got louder.
There you go.
That actually looked a little bit better. Okay. So this was her behavioral voice evaluation. Her RSI was 30, her VHI was 36, her Kate V was out of this world severe. But she didn't have a whole lot of tension when I was palpating, which was bizarre. Like you expect to feel these really tight muscles. I didn't. Didn't have elevation of the larynx. You would expect that with something like that. She did have a small thyrohyoid space, but she did hold breath when she talked. Here were her acoustic measures. She could hold a sound out for 21 seconds, but her range was abnormally high. So her lowest ability to get a pitch was 423 hertz, which is like crazy high. It's like talking like this. And her habitual was 367, which automatically is, I mean, you look at that and that's like, wow, that's not that great. An instance here again where capsular peak prominence was higher than 10, so it actually looks pretty normal, but the acoustic voice quality index is really above 3.46, so it's really high. Here's what she sounded like on Rainbow Passage.
Okay, the Rainbow Passage. When the sunlight strikes raindrops in the air, they act like a prism and form a rainbow. The rainbow is the division of white light into many colors, beautiful colors, to take the shape of a long, round arc.
So really breathy.
With its path high above.
Almost aphonic. Okay. What would you have tried? Think about it. I'm not going to put anybody on the spot and be like, what would you do? Because that's scary. But I will tell you what we did, what I did. Here's the excerpt from earlier. I did Roy's reposturing and strophonation, and that didn't work at all. She sounded exactly the same. But I went around and around with different SOVTEs, and I eventually landed on a tongue out raspberry, and we could hear her voice. And her main goal was really to find out what's wrong, but she really was pleased when she left today with a normal voice quality. Here's how she sounded just within that session, within just a few, I think I did 2 minutes, maybe 5 minutes of it. Here's what she sounded like.
Raindrops in the air, they act like a prism and form a rainbow. The rainbow, yeah.
She needed that.
The rainbow is the division of white light into many beautiful colors. These take the shape of a long, round arch with its path above and its two ends apparently beyond the horizon. There is, according to legend, a boiling pot of gold at one end. People look, but no one ever finds it. When a man looks for something beyond his reach, his friend says he's looking for the pot of gold at the end of the rainbow.
So I let the whole clip play there because I wanted you all to hear it wasn't perfect. There was some of that strain that was kind of creeping back in a little bit, but it wasn't what she came in sounding like. So my recommendations were voice therapy. I don't think she came back though. I think she didn't need to. And then just continue using the tongue out raspberries daily to re-coordinate. Case study number 2. This is the last one, and then we can open it for Q&A because we're close to 12, and I know you're all probably hungry for lunch. He is a male. He's 82. He had gradual voice change, swallowing difficulty. He felt fluid go down the wrong way sometimes, but he's bothered most by his loss of voice. So, something that maybe we can address later would be the swallowing. When he loses his voice, he can't speak, and he does not like that. And he reports a gravelly, unsteady voice with difficulty speaking loudly and strain to speak. Here was his initial strobe.
We have to take a breath in. Breathe in. E again. Good. Breath in and glide. E. Good. E. Good. And really loud. Go E. Good. Take a deep breath and then get loud.
So his supraglottic hyperfunction limits our view of his vocal cords, really. And it definitely limits his ability to sustain phonation. His VHI was 14, which was kind of low considering how much he really was reporting it bothered him. And he did have an abnormal acoustic voice quality index, and I thought his volume was soft, and he did have all of these things present as far as KV. So what would you have done with that person? Based on what you saw on the strobe, based on what you saw, which was vocal cord bowing in that exam, and his specific complaints. What did we do? We did Forte, and I think it was just about 2 sessions of Forte, and here's what he looked like. He came back. So automatically you can see more of his vocal cords during phonation. It's like, wow, there they are. He still has some squeezing of the false vocal folds here and here. But it's so robust. His sound, variable pitches, variable loudness levels. That's a really resonant voice. So asymmetry, but he sounds good. So is that disordered? He was happy. So at discharge that day, and I don't want you to be confused, we did 2 therapy sessions of Forte, but he did the Forte every day of the 6-day protocol. So he did that. And his VHI, when he came back, it was down to a 2. I could still hear some of this going on, but the loudness was no longer an issue. Interestingly enough, his AVQI didn't change much. So I thought that was very interesting. Just something to consider. Those are some real life case studies, because the feedback I get when I lecture is I want more of the meat. And so that was the meat. I'm going to open it up now to Hope to see if you all have any answers. If you have questions, I have answers maybe. These are references. These are included in your handouts as well. And this is just how to get a hold of me and look at the things that I do and provide for the community. So, what kind of questions do you have, if any?
Okay, our first question is the difference between spasmodic and muscle tension dysphonia.
Just what's the difference between them?
Yes, ma'am.
Okay, great question. Spasmodic dysphonia is a focal dystonia, is a disorder of the brain. It is a neurological issue where the ability for the brain to recognize that the vocal cords have been activated by motor output from the brain, there's no way for the brain to receive the message that, yes, we activated. So you have 2 different types. You have one where you get too much of that output And so it's that adductor spasmodic dysphonia where they can't control this happening. And they have brief periods of normal phonation, but there's a lot of extra strain in these kind of episodes that are usually made worse by stress. Abductor is where they're kind of going in and out, where they have these periods of breathiness, and it's really difficult for them to keep their vocal cords together. So the opposite is happening. Another muscle is being targeted, posterior cricoarytenoid muscle, where muscles, there's a pair, where it's opening when it shouldn't be. So that is neurological. Treatment is really limited for SLP services. Botox is a great treatment. Michael Pittman is working on specifically treating it with an oral, like in the ear, electrical stimulation, like implant, to help people like medicate themselves with that electricity. Kind of interesting research to read as well. They're still doing a lot of pilot studies from what I understand on that. And then muscle tension dysphonia is either primary or secondary. So secondary to like the 82-year-old we just looked at, secondary muscle tension dysphonia, just looking at the exam, because there was muscles activating that shouldn't be, secondary to presbyphonia. He had vocal cord bowing. It didn't look super symmetrically bowed, but he had some asymmetry there. Primary muscle tension dysphonia was what the lady had that we did the first case study on. It had come on from likely a traumatic event that she had experienced, and she had not been able to reset the neural components in her brain of what phonation actually was made of, and so what became normal and typical, and then therefore reinforced over 2 years, was talking like this. And that happens very, very frequently. But we're starting to find brain changes in those people too, that something keeps them in that way of vocalizing. It makes it really difficult for voice therapy to take hold and to maintain improvement. You hear about a lot of these chronic sufferers of MTD. So interesting. One's neurological and brain based, and the other one's more behavioral based.
I don't believe we have any more questions. Thank you so much,
Okay,
Dr. Bacher,
cool.
for joining.
Thank you. If y'all have other questions and you just feel scared to talk, cool. Thank you. Just email me or message me on Instagram. So thanks, Hope.
Thank you.
Y'all.